Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 59th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Managing Low Back Pain, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on both the IBJI and the NSYMCA websites. According to the World Health Organization, low back pain has the highest prevalence globally among musculoskeletal conditions and is the leading cause of disability worldwide. It is also the condition where the greatest number of people may benefit from rehabilitation. Chronic low back pain is a major cause of work loss and participation restriction, as well as reduced quality of life, not just in the United States, but all around the world. Considering the high prevalence, low back pain contributes to a huge economic burden on societies. People can experience low back pain at any age, and most of us will experience low back pain at some point in our lives. That's why tonight, Illinois Bone and Joint Institute's Mehul Garala, MD, will discuss low back pain and the symptoms, causes, and treatment options available to help alleviate low back pain. As a double board certified fellowship trained physician, specializing in physical medicine and rehabilitation, plus sports medicine, Dr. Garala is known as a physiatrist. He is mainly a spine specialist focusing on non-operative spine management, but has lots of experience treating a variety of conditions, many of which I will list in a moment. Dr. Garala has been in practice for more than a decade and has been with IBJI since 2018. He believes that the biggest key in working with his patients is patient education. He also strives to educate himself about his patients and their needs. While building a solid rapport with each patient, Dr. Garala learns how their particular impairment impacts their everyday life. He then works with them to optimize their function through lifestyle modification, medications, physical therapy, and the potential of spinal injections. One of the huge advantages of working at IBJI, says Dr. Garala, is his ability to provide direct care. In this model, he is able to efficiently see patients, quickly identify what they need, and start treatment almost immediately. Dr. Garala is a non-operative conservative specialist whose goal is to improve patient outcomes without having to refer people to a surgeon, making him the ideal doctor to cover tonight's program, taking us through ways to manage our low back pain. He has a wide range of experience, including neck, mid, and low back pain, buttock pain, peripheral joint pain, osteoarthritis, spondylosis, cervical and lumbar facet syndrome, radiculopathy or pinched nerves, degenerative disc disease, cervical and lumbar stenosis, sacroiliac joint dysfunction, sacral insufficiency fractures, spinal compression fractures, lumbar stress fractures in pediatric and adolescent patients, myofascial pain, coccydia or tailbone pain, sports injuries, and fractures. I list all of his areas of expertise because you may find that besides managing low back pain, Dr. Garala could help you or someone you care about deal with these other conditions as well. In fact, we think Dr. Garala is so great that this is now his third YMCA Education Series program, the only three-peat doctor to date. His first was only our 5th presentation back in July of 2020, when these webinars were just getting started. He then presented our 29th program early in 2022. And Dr. Garala, we cannot thank you enough for your willingness to share your expertise with our audience yet again tonight. During Dr. Garala's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the questions section on your screen, and I will receive them and relay them to Dr. Garala immediately following his presentation. I do ask that you please keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions for Dr. Garala, please contact him via one of the options that will be listed on the slide during the question and answer portion of our program this evening. One last thing before I turn the evening over to Dr. Garala. Please note that this series will be taking a break during the month of December, and mark your calendar for our next IBJI and YMCA Education Series program on Tuesday, January 21st at 7 p.m., Dr. Paul Goodman will discuss myths and expectations about bunions. Thank you again for joining us tonight, and thank you, Dr. Mehul Garala, for your time and your effort in putting together this program to help us manage low back pain. Dr. Garala, please take it from here.
Well, thank you for the lovely introduction, Karen. You can hear me okay?
Yep, we sure can.
All right, so I am just going to. So I've been practicing at Illinois Bone and Joint a little over 6 years as a non-operative spine specialist, and obviously I'm going to be giving a talk about back pain. But I did want to disclose that I have degenerative disc disease, as well as degenerative hair disease and degenerative skin disease. Well, let me rephrase that. When I meant to say degenerative hair disease, I meant to say gray hair. And when I meant to say degenerative skin disease, I meant to say wrinkles. And when I said degenerative disc disease, I meant to say normal age-related changes to my back. The famed author of The Jungle Book, Rudyard Kipling, said, "Words, of course, are the most powerful drug used by man." So how many of you guys have gone to the doctor's office to be told that you have a certain condition and thought the worst thing possible? Take degenerative disc disease, for example. It implies that your back is deteriorating and it's a disease process. You then go home and you go on the internet and you do further reading and go down the rabbit hole. So the objectives that I would like to cover today are to review or simplify basic information about back pain, dispel common assumptions or myths, go over the anatomy, which is important. So when a doctor is discussing possible structural sources, you have a better idea of what they're talking about. Go over what I use as an assessment for my patients, review treatment, and to follow that with any questions that the audience might have. So why am I giving a talk about back pain? Well, as Karen mentioned in the introduction, it's very common. About 80% of the population is going to have at least one episode of back pain in their life. It affects about a quarter of the working population and has a high recurrence rate. It's one of the leading causes of doctor visits. Now, one of the first questions that I have patients ask me is, why did I develop back pain? And sometimes it's obvious. There's a cause and effect, such as lifting a 100-pound box off the ground, or exercising at a gym, doing a rowing machine, or repetitively hitting golf balls at a range. Well, what if it's more innocuous, where someone just wakes up with back pain, or do something trivial like bending over or even folding laundry? One of the first assumptions is that back pain is only activity related, when I just sort of disclosed that it isn't. All those episodes that I just mentioned are actually episodes that I had when I had back pain throughout my life. What we know is that there's a lot of risk factors involved. The current theory is back pain is a biopsychosocial model. So obviously there's a mechanical component, such as heavy lifting or repetitive twisting and bending. So I'm talking to you, golfers and paddle tennis players. Genetics can play a role. Nutrition to our spine, in which smoking can influence. But also, as I mentioned, there's a psychosocial component. The centers of our brain that are responsible for interpreting pain are very close to our emotional centers. So having a psychologically stressful job, having anxiety or depression can influence pain. People that are not happy with their job or have a low socioeconomic status can also be at higher risk for pain. So I answered the why, now the what. Patients come in and say, why or what is causing my back pain? So another assumption is that if it is activity related, it has to be related to a herniated disc, or if it isn't related, that you just woke up with back pain, that has to be something serious like cancer. Obviously, herniated disc and cancer are potential causes of back pain, but there's also other structures. Muscles can be involved, other components of the bone, such as end plates, fractures can be a source of pain. The joints in our low back and the joints in our buttock area, called the sacroiliac joints, can be a source of pain. Nerves like sciatica or radiculopathy is the medical term, can be a contributing factor. And sometimes it's not even related to the back. It could be related to kidney stones or an aneurysm in the abdomen. I actually diagnosed a patient who had shingles as a cause of back pain. So I want to take a little bit of a deeper dive into the anatomy to give you a visualization of the potential structures of pain. So the low back, known as the lumbar spine, is comprised of 5 bones called vertebrae. And they're listed from top to bottom: L1, L2, L3, L4, L5, and then it sits on the sacrum, which is the buttock bone. And in between the bones is a jelly-filled donut, the disc, which acts as a cushion. Right above the disc and right below the disc is a component of the bones called the end plates. The vertebrae then extend backward and form these joints in the back called facet joints. This is an image in which the nerves are being demonstrated coming out of the spine. This is essentially the area where, when someone says sciatica or a pinched nerve, where that is actually occurring. So to break it down a little bit more, the nerves come out from the spine in these openings called the foramen. And 2 of the most common sources of a pinched nerve is either a herniated disc. So think of the disc as a jelly-filled donut. The jelly has squirted out and then is pinching the nerve. Or another common cause is due to arthritis. So arthritis can cause an overgrowth of bones and joints, which causes a narrowing where the nerve exits. So this is called foraminal stenosis. And that can also be a cause of a pinched nerve. On the right-hand side, you'll see a cross-section of the spine. And so you have the bone, and then you have the canal. This is called the central canal, which houses the spinal cord. And sometimes due to arthritis, that can be narrowed. And then by definition, that's called central canal stenosis. Now, the low back sits on the sacrum, which is the buttock bone, and that articulates with the pelvis. And there are these 2 joints, one on each side, called the sacroiliac joints, which are a common source of buttock pain. Now, in the front of the pelvis are where the hips are. So I have a lot of patients that come in and say, Dr. Garala, I'm coming with hip pain, but they actually point to the buttock area. So the odds are, if you have buttock pain, it is not due to hip arthritis. Hip arthritis usually presents with pain in the front of the hip where the groin is. Now, when I see a patient, obviously the location of where their symptoms are coming from can clue me in on the source of pain, but there's other things that I inquire about, such as, is there a mechanism of injury, other factors that can make the pain better or worsen it, and other things that I'm assessing just to try to determine where the pain is potentially coming from. The other important thing that I'm trying to assess is to rule out anything more significant. So if a person has cancer, I do want to screen that there's not anything potentially going on in the spine. There are common cancers that spread to the spine: breast, lungs, thyroid, kidney, and prostate cancer. The way that I remember that in the mnemonic is BLT, ketchup, and pickle. So BLT meaning breast, lung, thyroid, ketchup meaning representing the kidney, and then a pickle meaning prostate. The other thing that I want to assess for, if someone is immunocompromised, they have night pain, chills, a recent infection, I want to screen them if they have any potential infection going on in the back. Another yellow or red flag is someone that develops significant weakness in their leg, such as a drop foot, which might be indicative that a nerve is really compressing or being compressed. And then the last thing is if they have any signs or symptoms due to a rare condition called Cauda-Equina syndrome. This is a condition that happens in about 1 in 100,000 patients where multiple nerves in the back are being compressed, usually due to a large herniated disc. And patients usually will present with a lot of weakness in their legs, numbness and tingling in the legs, numbness around the anal area, and patients will have difficulty controlling their bowel and bladder. Now, in addition to getting a good history of present illness, I also perform the physical exam, which can clue me in on where the source of pain might be coming from. The nerves that come from the spine are big highway systems of information, and if it is impacted, sometimes it can send signals of pain traveling down the legs, but it also can lead to weakness, sensation changes, as well as reflex changes, which again can clue me in on a nerve is being pinched and where exactly that is occurring in the low back. Now, we supplement our assessment with diagnostic tests. One of the first things that we can do upon your initial visit is to perform X-rays, which are good at evaluating bone structures. But sometimes we need to order an MRI, which provides best detail of soft tissues. CT scans can also be performed if we're looking, we want more in-depth detail of the bones. Sometimes patients that have pacemakers that cannot undergo MRIs need to undergo CT scan. And there's also a nerve study that we can sometimes refer patients to further assess if they're supporting evidence of a pinched nerve. Now, as I mentioned, X-rays are usually the first things that we obtain in the office, and it's very helpful at looking at the bony architecture of the spine. One of the things that we can assess for is a fracture. So if someone has a history of osteoporosis, which are weakened bones, and they come in with acute back pain, we can assess if they have a compression fracture. Based on the anatomy, the vertebrae look like squares or rectangles, but if you see a compression, that is a clue that they might be symptomatic from a compression fracture. Younger athletes sometimes could get stress fractures, so an X-ray can sometimes clue us in on that. If there is cancer, sometimes it can show up on X-rays. And we could also assess other aspects of the bone, including the alignment. Now, patients will sometimes ask me, Doc, why are you bothering with an X-ray? Why don't you just get an MRI? An MRI will pinpoint the source of my pain. Now, as I mentioned, an MRI can give us good soft tissue detail. On the left-hand side, you'll see a side view. This is very similar to what I showed you on the anatomy diagram. You have the bones, you have the disc, you have the side opening where the nerves come out, and then on the right-hand side is a cross-section. So you can see the disc, and you can actually see the inside part of the canal where all the nerves are. Now, I'm sure a lot of you who have back pain have had MRIs, and this is an example of a report. And you can see various things that are listed. It's very confusing, very dense, and the overall impression shows a lot. There's mild findings, severe findings, and so when someone reads this, they can be overwhelmed. But a common misconception about MRIs is that it is a pain study when it is not. It is an anatomical study. The structures of the spine will undergo natural age-related changes as we get older. Just like we get gray hair and wrinkles, and we see that as a normal age-related phenomenon and not a disease process, we're gonna see age-related changes to the spine, such as bulging disc and arthritis. As we get older, these findings are gonna become even more common. This table actually demonstrates the incidences or prevalence, I should say, of certain findings in our back for people that have zero back pain. And you can see at the age of 20, about 30% of patients are going to have disc protrusions or herniated discs. At the age of 30, 50% are going to have some sort of disc degeneration. Again, I hate to use that term, but degeneration essentially is lack of or less water in the disc. So it is very common, and it should be understood that as we get older, there's going to be incidental findings that are going to show up on the MRI. So it is very important that we correlate the MRI with the patient's history and their physical exam to see if things match up. And even if it does, there's not exactly a one-to-one correlation between the anatomy and the clinical symptoms. So small herniated disc can cause severe pain, but at the same time, severe arthritic changes may cause minimal symptoms. The other thing that we need to consider is, why are we getting the MRI in the first place? Is it going to change our management? Now, obviously, if they're yellow or red flags, or if we're considering the patient may need to be seen by a surgeon sooner than later, yes, absolutely, we need to order it. But there is evidence that knowledge of imaging findings don't alter outcome necessarily unless there's a yellow or red flag, and it's actually associated with a lesser sense of well-being. We also have to be mindful of insurance guidelines. Most private insurance companies will want us to treat the patients with conservative treatment first, including medications and physical therapy, which I'm going to discuss in a short period of time, before they will even approve of getting an MRI. So the main takeaway is that when we look at MRIs, we are treating the patient. We are not treating strictly the imaging study. Now, this all leads to, what do we do for treatment? Now, in my opinion, there is basically 5 general categories of treatment in orthopedics: observation, medications, physical therapy, injections or procedures, and then surgery. Now, the goals of treatment is, obviously we want to reduce your pain, we want to improve your quality of life as well as your function, and promote well-being. Now, treatment is very individualized. It is based on your subjective pain, your quality of life, your function, your prior treatment and the results, your frustration level, and the willingness of what you want to do from a treatment standpoint. For example, I have treated a lot of patients where I discussed injections, but whether because they are afraid of needles or they just don't have a desire to proceed, they don't want to pursue that option. Now, observation for back pain is rooted in the fact that majority of people actually do well over time, even if nothing was offered. Approximately 60 to 70% of back pain will resolve in 6 weeks, and 90% will recover in 12 weeks. There is some evidence that actually that is 90% improvement actually occurs in 6 weeks. So if your symptoms are minimal, tolerable, and not leading to any functional limitations, you can simply just observe and see if your body will heal itself. Now, even with patients that have pinched nerves, which sometimes takes a little bit longer, they too can improve with conservative treatment. There's actually evidence that if there's a herniated disc that is pinching a nerve, the herniated disc can actually shrink over time. Now, when someone has back pain, I suggest to them that they modify their activities. They obviously can do things as tolerated. Now, if they have a herniated disc, I might be a little bit more cautious of what they can or can't do. We do want them to avoid bed rest, because laying in the bed actually delays the healing process. And essentially, when it comes to sleep, you just want to sleep in a comfortable position. There is not any evidence that the type of mattress you use makes a difference. So you don't need to go out and spend thousands of dollars for a new mattress if you have back pain. We prescribe medications in hopes of reducing the pain, but specifically to reduce the inflammation that might be a contributing component. So we prescribe things like a Medrol dose pack, which is a 6-day taper, or we consider non-steroidal anti-inflammatory medications. Now, there is no evidence that one anti-inflammatory medication is better than the other. Everyone has different receptors in their bodies, and genetics play a role. Some patients respond to ibuprofen, some people respond to Aleve and other anti-inflammatories that can be prescribed. Now, we do have to be mindful of certain contraindications. A Medrol dose pack can increase blood sugars. So if you have diabetes and don't have the best controlled sugars, we have to be cognizant of that. Non-steroidal anti-inflammatory medications, if taken for a long period of time, can affect the stomach lining, can affect the kidney function, as well as the cardiovascular system. So if you're at risk of a heart attack or even a stroke, sometimes NSAIDs would be contraindicated. There are other medications that we can consider. I know that sometimes Tylenol by itself might not be helpful, but it is usually safe to take in conjunction with an anti-inflammatory as well as other medications. Sometimes we consider muscle relaxants. I typically prescribe muscle relaxants because it does cause sedation, which is not a bad thing if people have problems sleeping at night. Pain meds sometimes can be offered in the form of opioids, but we all know that there's an epidemic when it comes to opioids or narcotics. So we have to be mindful of the side effects and the risk of addiction. And there's nerve stabilizers, which are meds specifically if someone has signs and symptoms of a pinched nerve. Now, I'm a big proponent of physical therapy. In order to optimize the health of the spine, the muscles also need to be optimized. The muscles act like guide wires or support structures for the spine. In a practical sense, there's a lot of things that we cannot modify when it comes to the spine. We cannot change our age-related changes. We cannot change our genetics, but we can always work on optimizing the muscles no matter our age. The other thing to keep in mind is that physical therapy has to be individualized. Everyone is different. Some muscles are weaker than others. Others have flexibility issues. So I usually recommend a one-on-one individualized physical therapy program instead of just a generic regimen for patients. Now, I have some patients that come in, they don't even want to worry about the meds and physical therapy. They just say, "Doc, why don't you just give me an injection and my pain will go away?" Well, there is not a specific medication that can be simply injected to eliminate pain, unfortunately. Now, there are medications or even pain procedures that can address certain components of pain, like inflammation, or to blunt its communication. Most pain procedures are target injections or procedures. There's not one injection or procedure that can address every single source of pain. We're looking at the potential structure, and we determine that based on your history, physical exam, and MRI or CT scan. It's not as simple as I hurt here, inject here. For example, if someone were to have a heart attack, a lot of times they complain of jaw pain or pain down the arm. So if a person comes to the emergency room and they say, "Doc, I have jaw pain, could you just inject me here?" You're gonna miss the source, which is actually the heart. So same concept when it comes to the back, we wanna deliver the medication to where we think the source of pain is. Now, a common injection that is performed is called an epidural steroid injection. Not all injections are epidural. So epidural is simply the space around the spine and the nerves that we are targeting, basically injecting steroid in hopes of reducing inflammation. Now, there are 3 different routes that we can introduce the needle to around the spine. It's called transforaminal, interlaminar, and caudal. Now, the determination of what type of injection is based on the patient presentation and the doctor's assessment of what is the best route to deliver the medication. Other injections or procedures can consist of targeting the facet joints, whether it's a steroid or a numbing medication that can lead to a potential treatment called radiofrequency ablation. There's also steroid injections that could be performed into the sacroiliac joints. Now, we usually do these injections under a special type of X-ray machine called a fluoroscope. A patient usually will come in and lay flat on their stomach, sometimes on their sides. And we use the X-ray to guide the needle into the appropriate location. This is an example of an interlaminar epidural steroid injection. You can see the needle in the center of the screen. We take different views. This is a little bit grainy, but a needle is coming off to the side as it approaches the designated area. We are able to confirm the location of the needle tip by injecting dye. This is a contrast to help us, again, determine we're in the right spot before then we inject cortisone. Now, a few things to note is that injections in the spine are not walk-in procedures. If you ever come into our ortho access clinic and you have knee pain or shoulder pain, there are some times where we can do injections right on the spot. But when we talk about the spine, these are considered more advanced pain procedures. We need to do them under X-ray guidance. So we need to get these injections approved by insurance company before proceeding. The results are variable. I wish we can always guarantee 100% pain relief, but there is, again, variability. So it depends on the presentation and a lot of factors on if you're going to see improvement or not. Now, these injection procedures can be repeated if necessary. We have to be mindful that insurances usually give us guidelines, but we also need to consider different treatment approaches if injections are not working or losing their efficacy. The definition of doing the same thing over and over again, expecting a different outcome. So if we're doing injections and we are not seeing any improvement, we need to consider surgery. Now, in my opinion, there are certain indications that surgery is recommended sooner than later. If you have intractable pain that is not responding to medications, physical therapy, or injections, and that is also associated with significant functional limitations, then surgery may be the best option for you. The other indication is if you have progressive neurological deficits. And what I mean by that is if a nerve is pinched, it can lead to weakness and numbness and tingling. If you have weakness that is getting worse, as I previously mentioned, it's telling us that the nerve is actively being compressed, and you need to alleviate that pressure sooner than later so things are not irreversible. And the last indication of surgery is what I mentioned before, cauda equina. You can see that I did not include herniated disc as an indication, or I would say a definitive indication for surgery. Most people that have herniated disc can improve over time. So if we are able to manage their symptoms, we're buying the body more time to heal itself. There are studies that have shown and compared people that underwent surgery versus conservative care for herniated disc. And what it showed was that initially people did tend to improve with surgery, but as they followed these groups of patients later on, it turned out they got to the same endpoint. So I discussed standard care, but there are other things that we can also consider. One of which is cognitive behavioral therapy and even sleep regulation. As I mentioned, the Center for Pain is very close to our emotional centers. So, people that are irritable, anxiety, depression, lack of sleep, these all influence pain. So working on that aspect. Acupuncture, chiropractic care are also something that people explore. There's not really any solid research that acupuncture or chiropractor works, but anecdotally, I've had a lot of patients that have responded. In my viewpoint, acupuncture has been around for thousands of years, so if it was a fad, we would not know about it. And the other thing to consider are advanced pain procedures. I've reviewed what are standard injections that we typically perform, but there's various other advanced procedures that can be performed for people that have pain. So in summary, I wanted to address that back pain is extremely common. It's not just related to activity. Majority episodes of back pain do improve over time. Herniated discs are very common. MRIs are anatomical studies and not pain studies, and that conservative treatment is an option with almost all cases for low back pain. So with that, thank you, and here to answer any questions that the audience might have.
All right, Dr. Garala, thank you very much. That was awesome, as usual. We really appreciate it. And we do have questions. So I will go ahead and start reading them to you. Kathy asks, do cushions for your back help if used on office chairs?
It's more anecdotal. So I don't think there's any real solid evidence that it can. I would say that you do want to put yourself in a position of comfort. There is some evidence that if you have a chair that is slightly reclined, you put less pressure on the disc. But otherwise, a cushion, if it provides comfort for you, I would say go ahead and use it.
Great. And you mentioned to find a comfortable sleeping position. Are there certain positions that make a difference with regard to sleeping that you might recommend people try?
The only sleeping positions that I might sort of recommend is someone that has stenosis. which is narrowing around the spine. So in general, people feel a little bit better in a flexed position. So they might want to sleep with their the head slightly elevated, or sometimes what people do is when they sleep on their back, they put cushions underneath their thighs to cause a little bit of a flexion in their spine.
Got it. That makes sense. Thank you. All right. And how about crossing your legs? Is that recommended or not recommended if you have back pain?
I would say if it's tolerable.
Perfect. Thank you. All right. Sharon asks, can a long-standing herniated disc in the lumbar area cause numbness and tingling in the toes and balls of the feet years after you've been diagnosed with it?
That is a possibility, but the other thing that we need to screen for is that there are different types of nerve conditions. So, for instance, peripheral polyneuropathy is where the small nerves in the feet can be impacted, and there's a lot of causes for that. One of the most common is condition is diabetes. So you'll need to be assessed and determine if that's coming from the back or elsewhere. I briefly touched base on it, but EMG study is a specific extension of the physical exam. It's a nerve test, and sometimes that's helpful to decipher a pinched nerve in the back versus a peripheral neuropathy picture.
Got it. That makes sense. Thank you. All right. Someone asks about, could you maybe talk about spondylolisthesis and the best way to slow it down?
Yeah, so there's different grades of spondylolisthesis, and there's different causes. So young athletes, their bones are still maturing, and so they can develop stress fractures that then lead to the slippage of one bone over the other. With adults that don't have that pre-existing stress fracture, sometimes arthritis can lead to it. Now, there's different grades from basically 1 to 4. When it's a low grade, like grade 1, we try to recommend physical therapy. I think that might be the best way to mitigate that from worsening because, as I mentioned, you're strengthening the core muscles. You're trying to stabilize that slippage. If it's more advanced, like grade 2, grade 3, then there can be some instability involved. And those patients sometimes do need to undergo surgery to sort of stabilize it.
Got it. Thank you. That makes sense. My daughter had spondylolisthesis and she was a gymnast. And when she stopped doing the back bends, it actually went away. She was able to strengthen and put it back, but she was young. Yeah. So, all right. You've mentioned a little bit about chiropractic treatment, but a few people ask, what is your view on it?
Yeah, so the reason why I put the slides of standard care is I don't think chiropractic care is standard. It's considered complementary and alternative medicine. And honestly, some of the philosophies are not in line of what we are taught in med school. So there's a different philosophy involved. However, at the end of the day, I share with my patients, I want them to get better. And so if they try medications and physical therapy, or if they have a good relationship with a chiropractor and they feel like they help, then who am I to say, no, don't explore that? It's just when it comes to research, there's not too much that shows that chiropractic care has been helpful.
Fair enough. Thank you very much. All right. What are your thoughts on ice or heat for lower back pain?
Yeah, so it's more anecdotal. There is not any evidence that one is superior than the other. People usually apply ice because they say it will reduce inflammation. People usually will apply heat if their muscles are tight and to increase blood flow and circulation. Both can be used if someone has spasms, but really it's just what works best for them. I would say you can sometimes alternate between ice or heat, but it's again, what works best to help with their symptoms.
That's great, thank you. Sounds like that's sort of a theme across the board. If it helps, do it.
Correct.
All right, great. Do you treat, and I'm sorry, I don't know how to pronounce this, paresthetica, notalgia, Paresthetica, paresthetica, notalgia. Do you treat that? This person is asking.
So, I mean, there's a lot of times paresthetica, I don't know if it's neuralgia or whatnot, but it's basically nerves. And so I say that the spine is one big highway system. So the big nerves that come from our spine then sort of form these smaller nerves. And these nerves also, as they become smaller and smaller, can get compressed at various locations in our body. So I would say if there's an identifiable source or component, yes, it can be treated. You know, obviously it does. There's different types of procedures and there's various things, some that I feel comfortable performing, some that I don't. And so I might need to refer a patient out to see one of our pain management colleagues. But I definitely couldn't help with the assessment.
Awesome. Thank you very much. That's great. That will be hopeful for that person that you could be helpful. All right. What is your opinion on decompression treatments?
Yeah, so there is actually a little bit of evidence. There's some better type of decompression machines out there, and a lot of it is through the chiropractors. But unfortunately, there's not what we call randomized controlled trials, which is sort of like the standard of if treatment is going to be really helpful or not. A lot of the studies are sort of retrospective studies where they do an analysis after the treatment to see if it's been helpful or not. And so there is some evidence that decompression devices can be helpful for people that have herniated discs. But keep in mind that when you see a chiropractor, a lot of times it's out-of-pocket pay. These decompression devices, they usually recommend up to sort of 20 sessions. So there's a financial component that you have to be cognizant about.
So if someone has had 12 sessions and their back still hurts, this person is in that situation, you might recommend that they look into something else since it hasn't seemed to work for them.
Correct.
Would that be right? Okay, great. Thank you. Awesome. Okay. Brandon is asking, what would you recommend that someone do if they wake up with lower back pain most mornings?
Yeah, I guess it also depends on what is the underlying cause. Because someone that has a herniated disc sometimes can wake up with pain. Arthritis is also notorious where people wake up with discomfort and stiffness. So I guess it depends on what the underlying cause is. Unfortunately, because arthritis is an age-related phenomenon and we can't reverse it just yet, if you do have arthritis that's contributing, it's more of like what you can do to manage the symptoms upon getting up of doing your morning stretching routine. However, if it's a herniated disc, then obviously, as we discussed, there are things that can be done to sort of help treat that. So
someone like that would probably be well advised to come see you and figure out if you can help them find the root cause of their pain.
Correct.
Okay. And then Sharon wants to know, and I think again, it would be come see you and you could help them figure it out. How do you differentiate kidney pain and low back pain?
Yeah, so part of it is the presentation and the assessment. If a person has a history of kidney stones, then that might be a clue. But sometimes when someone has kidney stones, it's a constant pain that is not impacted by a position or activity. In addition, on the physical exam, there are certain things. There's it's like a kidney punch test. So we're able to thump right where the kidneys are to see how a patient will respond. And so there's some things that could clue us in, but other times it's almost a diagnosis of exclusion.
Okay, that makes sense. Thank you. All right. Someone asks, is slouching bad?
Yeah, I don't know necessarily if slouching is bad. It's more along the lines of um, if you do it consistently, that it leads to the muscles and shortening of the muscles. And so again, going back to we need to optimize the muscles in our bodies as we all get older. And there's a lot of components, including the flexibility, the strength, the motor control, the balances between the right and the left side of the body, the front and back. So if you slouch for prolonged periods of time and it leads to shortening of the muscles, then that can impact potentially a risk factor for pain.
Great, thank you. Is AI changing care for the spine?
I would say no right now. My thoughts that over time, when it comes to MRIs and imaging study, there can be some patterns that could eventually be programmed into a system. So at least from an imaging standpoint, it may be incorporated. But I don't think it's really going to impact spine care because it's an art. It's an art of medicine. And that is something that comes with experience. Obviously, emotions and just reading, the patient. There's a lot of things that just can't be picked up by AI.
Makes sense. Makes sense. Thank you. Okay. Would you recommend foam rolling on your lower back, including your spine, for activity-related stiffness, something like post-tennis, for example?
Yeah, going back to if it feels good, that's okay.
Yeah.
I would say that the back muscles themselves do not get shortened. So it's more other components. I would say foam rolling would be very helpful to the quads, the rectus femoris. Stretching of the pelvis muscles can be helpful because keep in mind that the spine sits on top of the pelvis. And if there are tight muscles in that area, then that can obviously influence the back. So we need to focus not only the back, but the pelvis musculature as well. And so foam rolling those areas can be helpful.
Awesome, thank you. And so if someone has what they feel they might have like muscle spasms in their lower back, this person says, what about muscular lower back pain? So can muscle spasms be the cause of their lower back pain?
So muscle spasms is actually a symptom, not like a diagnosis. So
okay.
It's almost like what is causing that. Now, if the muscle is strained, that can cause muscle spasms. A herniated disc that's causing a pinched nerve can cause muscle spasms. People that have compression fractures can have muscle spasms, but it's usually a byproduct of an underlying condition.
Got it. Oh, that's good to know. Thank you. Okay. What are your thoughts on traction to help create space between the vertebrae?
Yeah, so there's not any evidence that traction provides long-lasting decompression of the spine. Actually, it takes a lot of force. I mean, we're talking about tons of distraction in regards to pressure to really distract the spine. And then obviously after you're done with it, everything comes back down into alignment. So there's not any overwhelming evidence that traction can be helpful long term. So with the neck, however, I know which it wasn't the topic of today's conversation, but cervical traction can sometimes be helpful at alleviating some of the tension on the nerve, but not so much of the low back.
Got it. Okay, thank you. That actually makes a lot of sense. Okay, we've got a bunch of thank yous. Thank you very much, very informative, people are saying. Is there an exercise regimen or program that you would recommend for low back pain?
Yeah, so this is where it's tied in. If you have back issues, where an individualized physical therapy program can be helpful. Because one of the most important things is that they're going to develop a home exercise program that is unique to you. As I mentioned, that everyone's body is different. I might have a tight muscle when it's loose on someone else. I might have weakness compared to someone else. And so the physical therapist, they're assessing you, not necessarily a diagnosis. They're going to assess your movement patterns, what muscles are weak, what muscles need to be stretched, and then work on a program that you can do on a individual basis at home. Ultimately, the goal that I would like to achieve for most patients is for them to be independent in their own care. I would love that they don't rely on coming to see a doctor, or they coming in to see a physical therapist, or seeing a chiropractor. So if they are able to establish a home exercise program, I think that's probably the best outcome.
Excellent, excellent. So that they can maintain a pain-free back.
Correct.
Awesome. All right. Someone asks if their diet could be a cause of back pain.
Yeah, I know that I get that question a lot. There's not any evidence about that. People talk about an anti-inflammatory diet, but the research that I've reviewed, there isn't anything that I can identify that it's related.
Okay, okay. Interesting. I've never thought of that as a question. So it's interesting you get that question a lot. It's too bad that you can't say, oh yes, eat this or don't eat that. That'd be helpful, but it's not the way life is sometimes. All right, is there a treatment or a cure for stenosis for the narrowing? Someone is saying stenosis or the narrowing, but I think stenosis is, well, I'll ask you. So that's the question.
There isn't, unfortunately. And so, but that doesn't mean that you're always going to be symptomatic from stenosis. Odds are there is a point where you were asymptomatic. And so what we're still trying to figure out from a research standpoint is like, what is the on and off switch? Like, why did all of a sudden you become symptomatic from the stenosis? But unfortunately right now, at least conservatively, there is nothing that can be done to open up that space. And that's why I think part of the evidence shows that when we talk about steroid injections for someone that has stenosis, it is literally a coin flip is going to be helpful or not. Because yes, it can help with maybe the inflammation of the nerves, but a steroid is not going to open up that space again. Gotcha. So, you know, if symptoms don't improve with conservative treatment, the meds, the physical therapy, the injections, the only way sometimes to really open up that space is with surgery.
Okay, thank you. And that was the next question. That's funny. So, okay, all right. So that was the, does it usually require surgery? Potentially.
Potentially,
right.
Correct. But as I mentioned, I want to stress, not just because you have stenosis doesn't automatically mean that you need to undergo surgery. There's a lot of factors that are involved. As I mentioned, it depends on your symptoms, your quality of life, your function, your goals. Usually when someone has stenosis, it presents with leg fatigue or tiredness. And so people might be limited with standing and walking for prolonged periods of time. We say there's a shopping cart sign. So when people go to the grocery store, they use the shopping cart, they actually feel better, but as soon as they stop it and they stand more upright, they have more pronounced symptoms. So part of the assessment is how much of that stenosis is affecting their function. Are they only able to walk a block before having to sit? And so those are factors that a patient needs to decide, you know, is that okay with them for them to take frequent rest breaks, or is that something so debilitating and frustrating that they will need to do something more?
Got it. Yeah, that's and I think it's all individualized. That sounds like what you're saying is,
Correct.
You know, each case is unique and you need individual treatment for your individual body and condition. Okay. Someone is asking, can you please provide more detail on ablation and other similar pain control approaches, and are they effective?
Yes, so radiofrequency ablation has proven to be a very effective treatment for back pain if your pain is coming from the joints in your low back. It's also done elsewhere. We do it on the neck joints as well. It is a 3-step process. The first 2 steps are diagnostic. So what we do under X-ray guidance, we are able to numb the small areas of where these small nerves are called medial branches are. And we essentially give you a pain diary Immediately afterwards, we want you to assess how your back feels. If you note a significant improvement with your pain and your function, it tells us that the area that we targeted is involved with your back pain. Now, the anesthetic that is injected will eventually wear off. And so then we would repeat the same diagnostic injection again using a different anesthetic. If you have similar results with pain reduction and improvement of pain, then you are a candidate for radiofrequency ablation. And what it is, it's a special type of needle that we can create a thermal lesion at the tip and burn these small nerves that supply the signals to the joints in your low back. Research shows that these procedures can provide up to a year's worth of pain relief. Last time I checked, the rough estimate is that 80% of patients could get 60% pain relief for a year, 60% of patients could get 80% pain relief for up to a year. And usually it's finite because the small nerves can grow back. So the pain can return, but you can repeat the radiofrequency ablation again if the first time was successful.
Very cool. Okay, thank you. That was an excellent way to explain that. All right, let's see. Some of these are getting kind of long, so it takes me a minute to read through them. That's sort of a diagnosis question. Oh, here's a question that a lot of people may not quite understand. What does bone on bone mean?
Yeah, so when we talk about a joint is basically where two bones meet, and there's usually a spacing between that. For the knee, it's the meniscus, but we have the bones in the spine are separated by a disc. So the disc is the space between it. And so if the disc loses water and it shrinks down, then sometimes the bones get closer together. And so when there's not a lot of cushion in between, usually due to soft tissue, then that's what bone on bone means.
And it sounds like some people might have pain with that, but a lot of people won't have pain with that.
Well, it depends. Usually when there's less cushion, then the bones become more vulnerable because the bones have nerve fibers as well. So you are increasing the odds that you will have pain when there's less cushion.
Gotcha. Okay. Okay. So you were mentioning that, a bunch of these things show up on MRIs, but that may not be one of the ones where, if you have pain there, chances are those bones are close together. And that'll show up that way.
About the spine, usually there's still some amount of cushion between the bones. It's not like the hip or the knee where there's literally no space between the bones.
Got it. Okay, thank you. All right. Are there symptoms that distinguish a pinched nerve from other causes of back pain?
Yes. So if a nerve is pinched in the back, it can lead to radiating pain traveling down the leg. The nerves supply muscles with their strength. So if there's weakness, that can be a tell sign that there might be a pinched nerve. And sometimes it can lead to numbness and tingling. Okay. Now, typically, the nerves that are pinched in the back, depending on which one, goes down the leg in a certain pattern or way. The most common nerves that are pinched are the L5 and the S1 nerve. The L5 nerve goes down the side of the thigh before transitioning to the front of the shin into the big toe. The S1 nerve goes down the back of the leg to the side of the foot. So sometimes by just the patient describing the pattern in which the pain travels, in addition to the physical exam, we can sometimes tell which nerve exactly is involved and which nerve is being pinched.
Great, thank you. All right, and I know there's a lot more questions because now they're really coming in, but we have 1 minute left, so I will ask this last one. If you would like to see Dr. Garala and get your personal questions answered, and I did skip over the ones that were more personal, where people told us about their surgeries and different things like that, please go see Dr. Garala. But do back issues sometimes cause gluteal pain, especially when sitting?
It can, absolutely. So a common source of buttock pain, and I don't know necessarily, the back, but the sacroiliac joints are one of the most common sources of buttock pain, but sometimes pain can be referred into the gluteal region. So herniated discs, pinched nerves can sort of go into the buttock area. Briefly, I know that a very common thing that is brought up is piriformis syndrome. Physical therapists use that term a lot, but research shows that piriformis syndrome is actually quite rare. It all just depends on the assessment and the physical exam, but the back definitely can refer pain into the gluteal region.
All right, Dr. Garala, thank you so much for your time. Thank you for your presentation. Thank you for answering all the questions. He is available in Glenview. You can reach out to him. Have a wonderful rest of your evening. And again, thanks, Dr. Garala, very much for your 3P. We appreciate it.
Thank you. Have a good night, everyone.
Thank you. Bye-bye.